Electro-Equiscope case study review. To get us kicked off, I'll introduce John Thorp, the founder and CEO of Intelligent Bioenergetics. One of the first hang gliders turned stuntmen, John used the earliest versions of this technology to avoid a knee replacement. And in time, he was invited to oversee the chronic pain division at Workwell Rehabilitation Center in Kaneohe, I think I said that right, as well as Castle Medical Center and Castle's Kailua Physical Therapy, and then later oversaw the chronic pain division in 3 more physical therapy centers on Maui that Castle had purchased. He has spent thousands of hours with patients from 12 technicians with 90% success rate. Based on his experience and research into Chinese medicine, John created the proprietary protocols that now make up the turnkey wellness-based methodology that he and his team teach to practitioners and technicians around the world. So it's pretty incredible. Hello, John. Over to you.
Thank you very much. The only one I'll tell you that can just about match me with about patients is who you're going to get to hear from today, and that's Dr. Ben Morovati. Dr. Morovati sees patients on a daily basis. He's right in Glendale or La Cañada.
Little Montrose, right in between Glendale and La Cañada.
Yeah, right in between. But I'll turn it over to Dr. Ben Morovati. I'll tell you, he's been tireless in his treatment. He's treated thousands of patients with the older as well as the new technology. And between the two of us, we have tens of thousands of hours. And so I proudly turn it over to Dr. Morovati and all the wonderful experience that he's had with this technology. Take it away, Dr. Morovati.
Thank you very much, Mr. Thorp. I'm glad to be able to do this. This is my first time doing this, so I hope you guys bear with me. I just learned how to push the right buttons. I always tell patients I've got a PhD in computers, push here dummy. And so I just went through a tutorial on how to use this program. So I'll try to do my best. I started off, as John was mentioning, with the Acuscope and Myopulse, the predecessors to the Equiscope, back in 1992. And soon grew to love the instrument because it was, in my opinion, the missing link I was looking for in treating the types of patients we see, which are primarily musculoskeletal patients. So a lot of the neck pain, back pains, and all that. However, having the instruments opened up a new door once I understood the physiology of what it actually does. So throughout the years, I've done seminars here and there, and one of the reasons I was talking to Lisa about having an advanced seminar is because I know by now pretty much everybody knows which knob does what and which wires and which probes do what, and the frequencies to use and all that. So she has asked me to come up with certain protocols. So in an office setting where you see anywhere from 30 to 35 patients a day, in a clinical setting, you don't have the kind of luxury, and I wish I did, to spend a long time with the patients, an hour, hour and a half with the patients. So coming from a background of working in urgent cares and in emergency rooms as an ER tech way back when, I got used to the fast pace of things. So I like to keep that momentum going in the office. I don't like to have patients wait. I like the fast pace. And so I had to come up with what worked for me. And I love the protocols John has because every time you use them, you get the same results. And that's the basis of the scientific finding, is if you can recreate the same results, doing the same thing over and over again. So I tweaked some of his teachings. I've tweaked some of my own experience, so to speak, and came up with protocols that fit in the anatomy and physiology of what's actually going on with the patient. So bear with me, and if you don't understand some of the stuff, you can always email me or we can always take it from there. and go from there. So I'm going to start off. Lisa asked me what kind of conditions can you talk about. I go, well, there's a gazillion conditions we can talk about. You tell me what's good. And so back and forth, and we came up with all the coronavirus scare going around and people coming in with sinusitis, including myself, with influenza being around. I said, why don't we start up here and we'll work our way all the way down. I'll go briefly and quickly through how we've treated sinusitis. I don't want to say treated. I don't want to go beyond my scope of practice. I'm treating patients, trying to get rid of the inflammatory process that happens to be called sinusitis. So itis is inflammation, whether it's sinusitis, tonsillitis, myofasciitis, or any itis. It's an inflammatory process in the body, simply put. To simplify what the Electro-Acuscope does, it takes tissue and normalizes the setting. When you normalize the environment of cells, you get rid of inflammation. Okay? Very simplified, crash course in what we're planning to do. So when a patient comes in and says, I'm having headaches and I've had the sniffles and all that, I don't tell them, I'm an ENT, that I'm going to treat you. As a matter of fact, I just came from my friend's office who's an ENT, and we work together really well. He sends me a lot of TMJ cases. He's a medical physician, ear, nose, and throat, and has been a patient himself and sees the benefit of this. Actually, I've seen his wife, kids, mother, and he is understanding how this whole thing works. And it's incredible the kind of results we've gotten just by trial and error. I'm going to show you a slide right now. I'm going to show you a picture of a patient I saw a week ago. Okay, so let me see if I've got the push your dummy thing. Screen share. Click. Let's go here. Click. And then I'm going to share this with you guys. So this was a patient I saw 3 times. So this patient had 2 sinus surgeries. And on the 3rd one, they scraped her sinuses and cleaned out everything. They removed polyps. They removed all kinds of bone chips that they said that was causing problems for her. And she still couldn't breathe right, and she couldn't smell. After the 3rd surgery, she lost her sense of smell. She came in, ironically, for sciatica, which I'll talk about later on. Once we treated her sciatica, she asked me, well, what does this machine do? And I told her, it just tries to normalize tissue. It takes away inflammation by normalizing tissue and so forth. And she goes, man, I've had these sinus problems. I've had 3 surgeries. Is there anything you can do for this? I go, I'm not going to treat your sinusitis. I'm going to try to normalize the tissue around your sinuses. We could always try it. And my deal with all my patients is give me 3 trials. And if it works, we continue. If it doesn't work, we stop. And if you're not satisfied, I'll refund you. So lo and behold, after her 3rd treatment, she calls, she goes, I don't know what just came out of my nose, but right next to the quarter, I don't know if you guys can see this white mass here. It's fibrous mass. There's some mucus around it, but this big fibrous mass, she came out of her nose. She doesn't know what it was. I still don't know what it is. She saved it, and I had her take it to her ENT and send it to the lab to see what's going on with that. She's extremely happy because now she can breathe easier. And when she says when she left our office, she could actually smell the bakery down the street for the first time in 5 years. She's coming back for a 1-week follow-up next week, and we'll see how she does then. I'm in close communications with her ENT because he called and wanted to know what this machine was. So how did we treat her? This is what we did. We started off by having the patient in a supine position. She's laying on her back, okay? And we take the 2 single handheld probes and we start with mode 1 and work where these areas right here. Well, let me go here. I can't show you sinuses. This program is geared to musculoskeletal diagrams, but the sinuses are right behind these muscles, okay? So for the sake of argument, let's assume that these are the frontal sinuses here. And so we took the two single probes, and once again, making sure that the gel doesn't touch. So Moses parted the, let's see right here. So we have one probe here and one probe here. And we treated this area for a total of 4 minutes at a frequency of 10, 20, and 40 finally at the intensity that the patient could tolerate. Initially, she couldn't tolerate any more than 200 milliamps. She saw flashing lights, but as we worked the area, she was able to go all the way up to 600, okay? After 4 minutes of work in this area, we went right down here to where the sphenoid and mastoid sinuses would be. And once again, these are the muscles that are in the general area, okay? So we work right around here. For same settings for a total of 4 minutes. Then we have her turn her neck to the side, and we work the sternocleidomastoid muscle. Why? Because the sternocleidomastoid is where the lymphatic chain, the cervical lymph nodes are. Okay, let me see if I can give you some lymph nodes here. Lymph. See all the green stuff? Those are the lymph nodes. Okay, so patients forget that you also have a sinus back here. It's called the mastoid sinus. It's like a reservoir. I explain this to my patients as a big water reservoir that needs to drain through here. So if you have myofascial trigger points, if you have hypertonic or tight sternocleidomastoids, if you have any kind of occlusion and lack of lymphatic drainage, that will hamper the drainage of the sinuses in general, okay? So therefore, we treat the sternocleidomastoid muscle on both sides. So we turned the patient around and we did this area here. We went to a setting of 10 hertz for 2 minutes and then 40 hertz for 4 minutes on each side at the highest intensity tolerated by the patient, which was 600. Now, following this, we do the chiropractic aspect of everything is to do cervical manipulation. Now with otitis media, which is ear infection in little kids, the British Medical Journal has shown that manipulation of the upper cervical spine is beneficial in clearing otitis media. And from my understanding, in England, osteopathic physicians will manipulate children for otitis media, and if it doesn't clear after 3 to 4 days, then they'll put them on antibiotics rather than just jumping on antibiotics right off. I have 2 DO patients who have sent their children for that same reason to me. However, there's not a patient that doesn't leave this office without having the Electro-Equiscope used on them, but there are a lot of patients that leave this office without any kind of chiropractic manipulation, because we do see a lot of chronic arthritic patients, all right? So I love to use the non-latex gloves. This is the 2 single probes right here, here, and then we take the pad, place it on C1, C2, right on the base of the neck, and then work the sternocleidomastoid on both sides, and then do the manipulation, and that was that. The whole thing takes about 15 to 20 minutes, all right? Now, what I love to do in conjunction with all of this is use the auricular probe, okay? I was fortunate enough to take the courses through Terry Olson. He's a PhD from UCLA who teaches auricular therapy and has written a book on auricular therapy. So auricular therapy is ear acupuncture points to stimulate the areas in the brain which control the areas of the body, okay? Instead of guessing where to stick the needles in, I find this a lot more effective because based on the biofeedback, you know exactly where to go to, and we do the auricular therapies as well. Patients always Clinicians always ask me, which ears do you use? I go, I do both ears every time. It takes about 2 to 3 minutes per ear, and it adds a whole lot to the treatment plan. Most often, patients will get off the table and say that they feel very euphoric. They feel like they're high, and I tell them that's the endorphin release. We hydrate our patients. We encourage hydration. You have to realize that the way the instrument is working is by trying to induce electrolytes intra and extracellular. So the more electrolytes you have, the better you're going to respond. The more dehydrated you are, and I'm not just talking about water. Water is just H2O. I'm talking about all the minerals you need in the system. So we talk about Pedialyte and all the non-sugar sports drinks to the patients. That is pretty much in a nutshell the protocol I use for sinusitis. And so far, especially this year, we've done this for 28 years, but this year we've had better results than ever before. And I think the reason being is this is the first year I'm using the Equiscope instead of the Acuscope and the Myopulse, which I have in the other 4 rooms. So that's that. Let me move on to something slightly below that, okay? So I told you I work with ENTs and I work with a lot of physicians and a lot of dentists. I'm a Loma Linda graduate. I was supposed to be a dentist myself, but here I am as a chiropractor, okay? So I know a lot of friends that are dentists now, and TMJ is one of those conditions which is very confusing to a lot of clinicians. And unfortunately, a lot of dentists, and I hate to say this, but I see it all the time. A lot of dentists take advantage of the situation and sell humongous appliances for thousands and thousands of dollars without truly understanding the myofascial component and the biomechanical component of the temporomandibular joint, okay? So the analogy I use with patients is your jaw is like is one bone, just like a garage door. I'm gonna go back to the anatomy. Okay, so let's get rid of the lymphatics. So you've got the mandible, the jaw right here. This is the whole bone itself, okay? So we can rotate it around. You can see it's one big bone. Here is the part of the bone that creates the joint with the other part of the joint, which not many people pay attention to, which is the whole skull right here, okay? Well, this is showing part of it, but this is where the bone articulates with the skull, okay? So, imagine the garage door, okay? You've got one door with 2 springs on either side. If one of the springs breaks, the door is going to wobble, go up and down crooked, okay? It's not because you don't have the right appliance in your mouth. And it's not because you have to get a new crown put in your tooth. It may be, but most of the time, it has a lot to do with the muscles of mastication, the chewing muscles. So we're going to go here and look at the function of the masseter here, okay? So when you chew, you can see how the muscle here has to contract and relax to create chewing action. Now, if you have one muscle here tighter than the other, let's say this one here is slightly tighter, it's going to deviate. It's going to deviate the mandible, okay? So that's one of the muscles we're going to address, and I'll show you how we address those. The other muscle that not many clinicians pay attention to is the temporalis muscle. So you've got the jaw where the mandible is part of the joint. The cranium is the other part of the joint. So the jaw is controlled by the muscles of mastication, but the cranium is controlled, these muscles right here, muscles in the back of the cranium, the neck muscles. So this is where chiropractic or biomechanics plays a major role. You can't just treat this area here and forget about the rest of the joint, which is here, and expect the patient to respond, okay? Does that make sense? Here's the back of the joint, right here. Here's the front of the joint. These muscles control the front of the joint. These muscles here control the back of the joint. These are all the chewing muscles. So the way we address TMJ is to take 2 probes again, put the patient flat on their back, okay, and begin with the temporalis muscle right here. All right? The temporalis muscle is one of the chewing muscles. We treat both sides. Now, you can get the gel in the hair. There's no problems with that. But you will definitely find myofascial trigger points in these muscles if the patient has what's called bruxism, where they're grinding and chewing a lot, okay? We start here at 0.5, graduate to 5, 10, 20, 40 at 1 to 2 minute increments, okay, depending on how the patient feels. Now, keep in mind, we're doing both sides at the same time, okay? From there, we come down to the masseter, right here. And then, does everyone have the oral probe? We go inside the mouth. One of the probes is inside here, and the other probe, the probe the patient's holding is inside the mouth. The other probe is by my technician here on the masseter. And we actually have the patient keep this rhythm going, open and close the jaw, okay? There's a chiropractic technique that's known as active release technique, which sort of mimics what we're doing with the Equiscope here, all right? The same muscle, the SCM is one of them, okay? We work the scalenes over here, the deep, deep neck muscles, okay? And we do both sides as well, okay? Now, once we're done with working these muscles here, so we got the temporalis, the muscles of mastication, the sternocleidomastoid, and the oral probe like John has here.
This is what I'm showing, the odontin probe.
Here you go, right here.
Doctor.
Right? Goes right in the mouth, okay? And then, this is a time to then transfer the patient to the headband or the ear clips, whichever is your preference, okay? We put the headband on, leave the room for half an hour, come back in half an hour, take the headband off. Then I do my active release technique with just the hands, just stretching the muscles a bit, do the upper cervical manipulation, and then follow up in 2 days. 3 to 4 treatments. If there's no marked improvement, if they're not 50 to 70% better, then we stop. I consult their dentist, I consult their oral surgeon. If a panoramic x-ray needs to be taken to see if there's any kind of problems with the condyle, we rule out all of that prior to all this stuff anyway. But make sure that there's no arthritic changes, there's no problems with the disc itself. All right? Now, could you treat someone with sinusitis of TMJs in one setting? Absolutely. If you get it down to a protocol where you're doing the sinus, muscles of mastication, all that, you're going to have a patient that loves you because it just drains everything. They get this lymphatic drainage. 9 out of 10 times they'll tell you, man, I'm swallowing all kinds of stuff. And it just drains into their throat. All right? So that covers the 2 major areas of concern up here. Right?
You know, the TMJ, TMD, and bruxing, protocol, that's excellent. Everything you just pointed out. Most importantly, is having the patient, when they actually insert the probe back so they can feel exactly where it's going inside there, and as they're doing that motion. And the only other thing that I add is at the end, I do a little with the smaller tips, a little Y probe massage on each side. And I kind of come down in through here with a little Y probe massage. That's kind of how I finish off most of my protocols. And I'm doing 6 stimulations, 12 seconds each, most commonly at between 10, 20, and 40. And that really, they love it. I mean, it's one of the best. And I think the whole dental world for what we're doing, I mean, it's a very simple procedure that can be done by anything. And it's just magnificent. And what the patients, the look on their face, they open and close their mouth. How could you do that? They're
Actually, one of my patients, who is a dentist, years ago when there was no Equiscope, it was just the Acuscope back then. His brother was my realtor and called me up and said, "Hey, look, my brother's a dentist. He's had this horrible headache. He hasn't been able to go to work. He is suicidal. He just doesn't know what else to do. He's taken everything on this planet." So I came in the evening to see him, and we treated him with the Acuscope in the suboccipitals, around the temporalis, 3-4 treatments later, and 20 years fast forward. He now is a proud owner of the instrument. He's up in Santa Maria, and he has Tuesday, instead of Tuesday tacos, he does Tuesday TMJs. Tuesdays, this is all he does. He's trained his hygienist and his staff to work the patients. And he keeps telling me, he goes, "Move up here. We have a line outside the door just for the instrument." So if there's any dentists out there that you want to work with, if I have to do it all over again, I'm all over the place right now with the sports medicine and all that, but I think there's such a niche for just doing TMD, because so many clinicians, whether they're MDs, DOs, DDSs, DMDs, DCs, haven't put everything together when it comes to the condition. You know, you go to one guy, he'll give you a night guard, and I tell patients, I go, the night guard is just going to prevent you from wearing down the enamel. It's not going to correct what's going on biomechanic. So anyway, that's that for the TMJ. So you can see how the neck muscles are huge and important in resolving temporomandibular issues.
My only other little addition, as much as I love the headband, is when you apply the ear clips, because these are all the facial acupuncture points. So one or the other, you can switch them up. One time do a headband, maybe the next time do an ear clip, and just kind of compare the notes on how the patient responded to both of them. Yeah. But that's the only thing I can think of. Other than that, just excellent.
Perfect. All right. So we are coming down the neck. I'm going to go over one more head and neck condition and give you a case study on this one. Had a patient, he's a Glendale PD. He walked in the door one day all suited up with his gun and all that, and I go, I'm looking for the doctor, and I'm like, oh my God, what the hell did I do wrong? You know, he goes, I hear that he can take care of my problem. What is your problem? And then I just brought him in. I go, come in, let's honor HIPAA. We don't want to talk in the waiting room. Took him in the office, and he goes, look, I've had this condition going on for 2.5 years, and I'm in law enforcement. I need to draw my gun. I need to wrestle people. I can't jeopardize my life, nor can I jeopardize somebody else's life. But I'm having this stuff going on with my neck and arm, and I've had EMGs, NCVs, had a couple of epidural injections. Nothing's really helping me. What can you help me out? Like everyone else, I tell them, I don't know. Come on in. We'll do 3 treatments. If it works, it works. If it doesn't, I've got my guaranteed program with you, okay? So he brought me all his MRIs and x-rays and everything. So we started treating the scalene muscles, okay? The scalene anticus has, if you look up the trigger point charts on the pain pattern, the pain pattern is in the neck, down the arm, thumb and index, halfway through the middle finger, and by the shoulder blade, and sometimes into the chest, okay? Let me go to the muscle real quick. And so these are the muscles. There's a whole bunch of them. The scalene medius is what's highlighted. I'll show you the action of the muscle. And once you understand the action of the muscle, when it comes to neck pain, most of my neck pain patients who come in with, let's say, left-sided neck pain, we treat the right scalenes. And guess what? All of a sudden, the left side resolves. It's all because of the biomechanics of how these things work, okay? So the muscle here contracts to the same side. So it will move the head to the same side, right? Just like that. So I have made it a habit to treat patients while they're moving in the direction of the muscle's action and trying to reset all the proprioceptors and nociceptors, all that good stuff there, okay? So right there. So the scalenes are very deep, and the reason they create havoc is because, let me go back here. By the way, I have these in every room, and I show every single patient what we're going to do, how we're going to do it, and why these muscles are so important. And once they understand all of this. It makes life a lot easier on them because they don't know what's going on half the time. They've never seen the instruments anywhere else. They've never, they're used to just going in and getting their neck adjusted or going in and getting some NSAIDs and so forth. So here I'm going to highlight the nerves for you. This is called the brachial plexus. These nerves, highlighted in the purple here, these nerves go right through the muscles, okay? So we can isolate the nerves for you right there. You can see how they come off the spine and go right through all the muscles and then underneath the clavicle down to the arm. So the analogy I use is a foot on a garden hose. If the muscle's tight, okay, and contracted, it's going to compress the nerve and it's going to decrease the nerve flow. If you have very slight pressure on a nerve, you can decrease the pressure, decrease the function by 50%. So let's go back here and, all right. So treating the scalenes, I like to use the Y probe or the compass probe. This right here, all right? Patients on their back. We work left and right. We start off with 5 for a minute. 0.5 for a minute. And then we go to 5, 10, 20, and 40 at 1 minute intervals, okay? We spend about 2 to 3 minutes at 40. We switch sides and do the same thing on the opposite side. We follow through with the auriculars, and that's the first treatment. The second and third treatment are strictly done on the symptomatic side, meaning we take a little probe, a little pad, 1 inch, and let's say it's the right side, okay? This will go right on the acupuncture point here, the Hoku point, on the right side, and then we will take the big probe here. I call it the Solis probe, Elvis Presley probe, the big one. Thank you very much, probe right there, right? And we go right in here and work the symptomatic side. One area you need to not forget is to go underneath the clavicle, right under the collarbone. A lot of people forget to go to that area. So right here, all of this, and follow through. Now, here's where clinical skills come into play. For every muscle that's in contraction, the antagonist muscles or the myotatic unit, all the muscles that create movement in that area are affected somehow. So if you have a shortened muscle on the right, the left side's compensating for it. The front, this side is compensating for it, and so is the back side. So then you go back to this with the Y probe and you work. I love to scan through at 40 and 600 milliamps. Scan through everywhere, find the hot spot. The patient will tell you, I'm looking for gold here. You tell me where the bruised-like feeling is. And when you scan through, within 20 to 30 seconds, they'll say, oh, you just hit a spot there. Once you find that spot, clean up the gel, because I don't want to disperse all the current in a big area. You clean up the gel to about the size of a tennis ball. And you can either work it like a compass, work it this way, or go with a single probe. We work the trigger points. Now, I try to keep it to about 3 to 4 trigger points per area. So if you're working the scalenes, you're definitely going to have one of the pectoralis. You're definitely going to have one of the infraspinatus. You're going to have one of the upper traps. You do those 4, you open up the myotatic unit, or the whole mechanical unit that controls this action, and allow proper nerve flow and venous and arterial flow. The arm feels a lot better. All right. You can take the same principle and apply it to the pectoralis minor. There's 2 entrappers that mimic disc impingement on the nerves. Okay. So, for example, a C5, C6, or a C6, C7 disc can cause and look a lot like a scalene anticus entrapment and a pectoralis minor entrapment. Okay. So, treating the pectoralis minor, no different than treating the scalenes. And this is where it gets really easy. After you spend a week in the office, a lot of clinicians who spend a week, all of a sudden they go, wow, I got it. It's the same protocol. We have called it lateral epicondylitis, rotator cuff syndrome, medial epicondylitis, tennis elbow, golfer's elbow, jumper's knee. We've given it all these names so we know where to go to look. But at the end of the day, the pathophysiology of what's going on is pretty much the same thing. Myofasciitis is myofasciitis, all right? Whether it's up here that's causing TMJ, whether it's here that's causing tension headaches, whether it's here that's causing TOS, thoracic outlet syndrome, or scalenothengus syndrome, pec impingement, sciatica, all of those, same protocol, you're dealing with skeletal muscle, all right? Is that simple enough? Let's go to the piriformis real quick. Well, before we go to the piriformis, I'm going to show you, this was the infraspinatus. So this is the supraspinatus, infraspinatus right here. These are the two major muscles that can and will cause problems just along with the scalenes up here, right? So we're going to go down to the piriformis. My dear friend piriformis. Big troublemaker right there, right? Here's a muscle that can cause sciatica, okay? According to Travell and Simons, there's different anatomical variations. In some people, this nerve, the sciatic nerve, the largest nerve in the body, right here, in purple, this nerve can either go underneath the muscle in a percentage of people, go over the muscle, and or go through the muscle. If you're one of the unfortunate patients where the nerve goes through the muscle and the muscle goes into spasm, or if you have myofasciitis, you're going to compromise the nerve flow. God only knows how many patients we've seen who've had injections, who've had manipulation, who've had everything else done to the back, with the exception of working the piriformis muscle the proper way. You don't want to get in there with your elbow and create more inflammation. You want to tonify the muscle. You want to normalize tissue. How do you normalize tissue? The Electro-Acuscope normalizes electrolyte exchange, right? It brings everything to homeostasis. That's what we're trying to do. So we go down here to these fibers in the muscle and make sure that it's exchanging the proper electrolytes to bring muscle to tonus. Another analogy I use is I tell patients, when your heart stops, what's the mechanism that gets the heart going again? I mean, I'm simplifying things a lot, but just to make a point, 2 paddles with some current, okay? You zap the heart, it starts working again. This is on a microscopic level. We're using current to get the muscle working again here, to go back into tonus, to tonify muscle. That's why I'm so against exercising and strengthening something that's already in an inflammatory and shortened state. And that's where I argue with a lot of my colleagues is like, no, during the acute phase, you want to tonify, you want to relax the muscle, you want to stretch the muscle. Hence, muscle relaxers. In our case, the muscle relaxer happens to be the Electro-Acuscope. Then, after you relax the muscle and the symptoms have calmed down, then you want to tonify, strengthening the muscle so it doesn't happen again. And that's where physical therapy or rehab comes into play down the line. Not during the acute phase, but after you've gotten rid of the pain, so to speak. So there's a protocol we use. We come to the piriformis, and we will start with 0.5 on the piriformis. Then we go down the nerve pathway. We go to this muscle here. There's 2 points that we do, one up here and one down here. And then we keep going all the way down. We follow the pain pattern, okay? We go back here, we hit a point here, we hit a point here, and we hit a point right down here. Finally, we go all the way down to the ankle and hit the point right where the pointer's pointing to, right down here, okay? All of these settings, we start off at 0.5, go to 2, go to 5, 10, 20, and 40 at 30-second intervals. And then we go and to the auricular points, work the auricular points for all the acupuncture points that pertain to the low back, which is pretty much way up here. Do the auriculars. Then I go through some stretching. I do some of the chiropractic stuff. I have what's called a Leander table. We stretch the patient. We do very gentle manipulation. I use ART, active release technique. Then do the manipulation, get the joint to move. And once you get the joint to move, things calm down even more. Once again, with these kind of patients, I see them every 2 days, not every other day, but every 2 days. And 3 to 4 treatments. Actually, the latest Yelp review we just got yesterday is from a veteran who now is an IT tech and works at the Veterans Hospital. He's had low back pain with radiculitis down the left leg, with a little bit of foot drop, meaning that he can't lift his foot too easily. He's had 2 epidurals. He's had several MRIs. He's had, the Veterans offers acupuncture and chiropractic nowadays, believe it or not. He's had acupuncture. He's had all the NSAIDs, the non-steroidal anti-inflammatories, and he's still having a problem. So he can only work part-time. We saw him yesterday for his final 6th visit. He's pretty much asymptomatic, meaning no more symptoms. Toe walk, heel walk is strong. Muscle testing is 505. He's got all his strength back. He's got full range of motion in the lumbar spine. And he wrote us a beautiful Yelp review without us asking him. And that's the kind of results you get with this. And I just don't know why it's not out in every single teaching institution, why it's not in every single office. I've got 1, 2, 3, 4, 5, 6 rooms with the instrument. And people come here just for that. As a matter of fact, I'm ready to divorce the name chiropractor because I don't want to be stereotyped into backcracker. I've come up with a name, and I've bought the name Myofascial Treatment Centers of Southern California. You know, that's what my scope of practices, that's what I do. And the itises, that's the added benefit. Any kind of an itis you have, we'll address. Okay? There was a question that a patient emailed me, and I was really busy today. I couldn't get back to him. I asked him to join in, and I think he's joined in. But this was for headaches, migraine headaches. So there's classical and there's the traditional migraine headaches. Once you've ruled out any pathology, once you've seen a neurologist and you've ruled out all pathologies, this is what I love to do. See everybody else, let them do my homework for me. Let them rule it out. I don't want to see any lawyers in my office, okay? And knock on wood, 29 years, no problems, okay? Rule out everything, and if everyone is throwing their hands up in the air, you can bet that this is going to work. It's going to work regardless. But you've done your due diligence, you've covered yourself, patient comes in. So with migraine headaches, first of all, pay attention to diet. Diet is a huge thing. You can do Equiscope forever, but if you have the perpetuating factor is an allergen that's causing vasoconstriction, vasodilation, then you need to identify that. If you've already done that and you're eating a clean, healthy diet, hydration, the American Cervicogenic Society says that I think 72% of all headaches is basically dehydration. Make sure you're hydrated well. Make sure it's not an allergic reaction to a medication. Okay? Rule all this out. If you've done so, then you want to work pretty much the TMJ stuff. Okay? Now, if you're having auras, if you're seeing flashing lights, if you have the photophobia, the nausea, vomiting, you have classical headaches, you might have to see a neurologist to keep that at bay and then incorporate this, and you'll see how you get better and better and better. If you don't have those symptoms, if you don't have the flashing lights, the nausea, the vomiting, the photophobia, most likely, when I was in school, they used to tell us when a clinician doesn't know what the diagnosis is, they say 3 things. It's in your head. You need to see a psychiatrist. Okay? It's arthritis. Or just take this, it'll get better on its own. It's not going to get better on its own. So try doing the trigger points all along the temporalis, frontalis, occipitalis, neck muscles, and correct the diet and see how that goes. And then email me later on and let me know if that worked. Oh, and the headband. Using the headband. Now, if you can go start at 0.5, let it run for 2 minutes. Just move up the dial. Move all the way up to 40. And if you're having an acute attack, you can go all the way up to 320. Okay?
Hello?
Yes?
Dr. Morovati, when we were in training, there was some discussion about not using the instrument at the jugular vein.
Yeah, well, the SA node is there. You know what that is?
No.
Okay, so that's sort of like a thermostat that controls your heart rate and all that. So in particular with younger patients, it's really sensitive and it can cause an episode of fainting or vasovagal syncope sometimes. That's one of the reasons why it's recommended not to work around that area. Now, you can go over it. It's the point they're trying to make is not sit there for 2 minutes and work it and massage it.
So where we're working on the neck for these issues, we're not getting close enough to make it a problem.
We're not pushing hard enough and we're not working close enough to make it a problem.
Okay, great. Thank you.
My pleasure. Now, having said that, if you notice the chair I'm sitting in one of my exam rooms. My chairs have armrests and a backrest because we learned through one mistake. When we had the patient sitting on the exam table, which is right here, let me show you. See the exam table right there? We had the patient sitting on the exam table, and while we were working the neck, she fainted and went straight into the wall. All right? So from that day on, we have them sit and lie back. We have a towel. We keep them nice and warm. We work on the neck. My girls are trained to ask questions every 15. Are you doing okay? If there's anything we can do, tell me right now. Are you cold? Are you hot? Are you thirsty? We have a bunch of Pedialyte here in the kitchen. We give people stuff to drink. We have all kinds of snacks to get their glucose level up because teenage girls, for some reason, don't eat anything at all. And they'll come in after school, which is 3:30. They haven't eaten all day. You treat them and they faint on you. And I'm like, you can't be doing that. So we ask patients, have you eaten? We want your blood sugar up. Patients who've been on a lot of medications, especially narcotics, will get nauseous and sometimes will throw up. There is a detox mechanism. When you're normalizing tissue, there's a detox mechanism that's kicking in. You're also creating lymphatic drainage. And that's when patients might feel nauseous and dizzy. But that's very transient. It takes 1 to 2 minutes. Hydrate them well, and they'll be okay.
If somebody is taking opioids for that pain,
yes.
How do you time the treatment? Maybe at the end
patients on opioids are going to respond a lot slower. Geriatric patients generally respond a lot slower because they're dehydrated. Patients that are on opioids respond slower. Everything is just at a mellower rate. They will feel nauseous. If you can get them to really hydrate and take the medication hours before you see them, that's going to help the most.
Great. Thank you very much.
No problem.
There's a question from Jean in the chat. Does this device work for arthritis in the shoulders?
Arthritis is a broad term. There's different kinds of arthritis, the arthritides in general. So arthritis of the shoulder. Now, if you have a bone-on-bone condition, if you have a condition where you have, let's say, avascular necrosis of the shoulder, it's not going to work. Once tissue is dead, it's dead. Okay? Now, if you have just an inflammatory process like osteoarthritis of the shoulder, if there's not a lot of wear and tear on the joint itself, it's going to work excellent. All right? So arthro means joint in Latin. Itis is inflammation. Remember what I said. We're treating inflammation, right? So we go and treat the inflammatory process. How do we treat the inflammatory process? Why is that joint inflamed to begin with? Are you sleeping on it all night? Did you have a traumatic event where you hung? Like I have a rock climber, he hung on one arm and he's got a lot of inflammation there. Do you have trauma to the area? Okay. If you've ruled out all of that, then you go to the myofascial component. The shoulder has a very shallow, small-ish, and a big old bone stuck in it. The way the shoulder works isn't so much related to the joint itself. It's all this tissue around it. The shoulder does what's called circumduction. It can go in 360 degrees. The elbow can only do this. The wrist does this, but there's 8 bones in this little area. You got 2 bones in this big area, okay? Now, how do you get rid of the inflammatory process in the shoulder if it is myofascial in nature? You want to treat all the muscle attachments that have caused the inflammatory process. How does this happen? I use the analogy of the horse and carriage, okay? So you're sitting in the carriage and you've got 8 horses, the Budweiser horses, right? You've got leashes, 2 leash per horse. So you've got 16 leashes that you're controlling, right? Imagine if one of those leashes pulls a little harder than the other leashes. One of those horses is going to want to veer away. That veering away, that tug of war that goes on, causes arthritis between the rider and the horse. Okay, it causes friction, inflammation. You need to balance all of the leashes to pull evenly. That's the rotator cuff. So you have the pectoral muscles, you have the deltoid, you have the infrasupraspinatus, subscap, teres minor, teres major, triceps, 3 right there, biceps, 2 right here. You want to work all these muscles, make sure they're toned right, make sure their tension on the joint is correct, and go for them at that aspect. Then you want to go to the auriculars. For some reason, auricular therapy works fantastic for shoulder arthritis. All right? You do the ear points. The whole thing shouldn't take more than 15, 20 minutes. And 3 to 6 treatments, you should be fine. If you have spurs, if you have degenerative changes where you're bone on bone, if you have a torn labrum, that's a different story.
I was diagnosed with thyroid cancer a little over 3 years ago, and I've made great progress with other holistic treatments like IV drips and so forth, but I don't think it's completely gone. Can this be used like directly on my thyroid, or I have a enlarged lymph node to the right inside of my neck that's decreasing, but it's still somewhat there?
Okay, so this machine does not cure cancer, but what it does do, it gives your body optimum power to fight the cancer.
Okay.
If you can get rid of as much interference, as much as gunk as you can, your chances, if you get your autoimmune up, which is what I'm talking about, then your chances are better. So if you can help the lymphatics drain, if you can get on the thyroid and decrease inflammation, okay, you're going to help matters. All right? We had another patient, actually one of my physician friends, which is a block over, he referred one of his patients who's in stage 4 cancer. She went ahead and bought a unit about 6 months ago. She was given 2 months. She bought the unit 6 months ago. She's still around. And I'm not saying we're curing cancer. I don't want to get in trouble. Right. But you can get rid of a lot of interference. You can bring your body to its optimum. I mean, after all, why do we always recommend patients to eat right and exercise? That's to bring your body to its optimum level, right? Why? So you can fight everything. Who's right now the most compromised patient with the coronavirus? Autoimmune compromised, the geriatric, unfortunately male, in my case, patient. That's what I'm talking about. So if you can bring your autoimmune up, I think it's going to do nothing but help.
Okay.
Thank you.
Thank
Bye.
you.
Okay, one more question from Dr. Maggie. Are the settings and time of treatments you discussed for the conditions the same in the Acuscope?
Yes and no. To a certain degree, yes. This is a faster, so it takes longer with the Acuscope. In my experience, having this for 2 years now, it's quite a bit faster. You can get the same kind of results, but it takes longer with the Acuscope.
So just realize, if you guys can hear me, what we're doing and what the Equiscope does, and I think this is what Dr. Morovati has found as well, with what he's doing with sinusitis and things like that, that how much better it's responding with the Equiscope is because there's technology built into the Equiscope that wasn't available with the older technology. And what that Equiscope is, it's a neural response device, which means as soon as you excite that tissue, you're capturing the behavior of the autonomic nervous system, both sympathetic and parasympathetic, and you're putting it into sympathetic resonance, which is harmony. You're strengthening the immune system. People don't understand that your immune system is based on your body's ability to hold charge. And what the Equiscope is doing is allowing your body to be the best battery it can be. It's strengthening the non-conducting medium so that it doesn't leak and go into premature apoptosis at the cellular level. Cancer goes after weak cells. We're not, it goes after a cell that's lost membrane potential. And so, if we can strengthen the surrounding tissue, then we can strengthen the body's ability to fight off whatever dis-ease it is. So it's whatever disease it is, whatever autoimmune system, whatever is going on in the body, you're strengthening the body's ability to heal itself all by itself.
Yeah.
Now, Dr. Morovati, everything you said was just excellent. I'm so honored that you're such a strong member.
It's my pleasure.
Been that way for, close to 30 years. I mean, for all that, time, I'm just, so this, for anybody that's out there, I mean, Dr. Morovati has done this for 30 years and he is very successful in everything he's done. So, I don't want to share you, but he's got a very, very strong practice as far as monetarily. He's I know it. I'm not going to give out the exact numbers, but it's huge. And I'm so proud of him and the work that he's done. So
I appreciate that, but let me tell you this: there's a lot of patients that come in and say, "I can't afford it," and I say, "Just come on down. I'll do the X-rays even for free. I'll if I can help people out, I'm here to help out." And they help me. I don't do any marketing or any advertising. They do the marketing for me. So I figure, why go spend all this money on marketing to inform people of this when you have the live body here and you can demonstrate on them? They're going to go out and kill 4 or 5 people, and it doesn't do that. All these years, that's been the best referral has been word of mouth, especially physicians. As a chiropractor, we had to sit in the back of the bus for so many years. I've got my number one referral source are physical therapists. They're supposed to be technically our number one enemies because we parallel each other so much in what we do. Physical therapists refer more patients to me than I got physicians, then I've got dentists, personal trainers, because Janet Travell, my mentor who trained me in this, she was a White House physician with Kennedy and Johnson. She was trained as a cardiologist, but she went into physical medicine. She used to always say that 85% of visits to the ER have somehow a musculoskeletal involvement. And if we can nip that at the bud in the clinical setting, the ERs won't be as busy. And so I took that, and my background is I went to Loma Linda University. I was a full tech, meaning I did angiograms, CT scans, MRIs. I worked at Cedars-Sinai. I was one of 2 chiropractors with hospital privileges at Cedars-Sinai, Glendale Memorial, Glendale Adventist. I co-authored a textbook called Manipulation of Anesthesia. I've done a lot of reading and a lot of studying because I knew there was something that was missing. And I'm telling you, I sound like a sales guy now. I'm not trying to sell the Equiscope, but it connects the dots. It connects the dots. And if I can help anyone, I've always been open. People come here all the time. I train them. I'll send them to John if they're down in the Southern California part of the San Diego area. It's been a great addition to the practice.
Thank you, Dr. Morovati. This
Pleasure.
was really wonderful. If you haven't checked out his website, it's morovati.com. It was in the email, so you can get the link there. And we'll send out the call recording by tomorrow.
Thank you.
Have a good night.
You too.